enable critical care in India. So what his company, Cloudphysician, does is it democratizes the delivery of quality intensive care to smaller and medium-sized hospitals using cloud-based platforms. I thank you so much for taking this opportunity to speak to us, and I'm sure it's going to be really insightful.
Thanks, Rohan. And thanks, Rohan, and thank you to the other organizers for providing me this platform to speak to you this afternoon. I hope by the end of my talk, I've been able to give you some insight on how technology can be leveraged to provide a high-quality care in the ICU. That's what I'm going to talk about today. Just a little bit of background on me, just some disclosures. I am the co-founder and director of Cloudphysician Healthcare, which is a Tele-ICU company based in Bangalore. Rohan already spoke about my background. I'm trained in critical care. I did my training in the US at the Cleveland Clinic and moved back in the end of 2015, where me and my other co-founder, Dr. Dilip Raman, found ourselves at the intersection of technology and healthcare delivery in the ICU, which was and we found ourselves with a unique problem, which was the shortage of trained intensivists or trained critical care specialists. And that is what motivated us to start Cloudphysician, and our journey has been fascinating since then. So let me just give you some background on what critical care is. So a lot of people confuse critical care with emergency care. There's a difference. So when you can find yourself going to an emergency room for a multitude of reasons, and when you go there and you are found to have life or limb-threatening conditions, and that is when you are admitted to an ICU, and that is what defines critical care. So I'm very specifically going to talk about ICU care. Patients who meet certain criteria that gets them admitted into the ICU. These are the sickest of the sick patients, the sickest patients in the hospital that find themselves in the ICU. And so that is specifically what I'm going to be talking about today. So critical care has moved leaps and bounds in the last few decades, and one of the biggest changes that have taken place has been the improvement in training of physicians. So critical care now is a subspecialty in and of itself. So just to give you some idea, having an intensivist has actually been considered, having a trained intensivist who is specialized in critical care has been found to be the most effective intervention to improve the survival of critically ill in the past few decades. And in India, also we've been a little behind in terms of training our doctors, but in the last decade or so, we have kind of caught up to some extent, but there's still a large problem here. All right. So what is a trained intensivist? A trained intensivist is a physician who has finished his MBBS, 6 years of MBBS, following which he has finished 3 years of specialized training, which can be in internal medicine or in anesthesia, following which he is specially trained in critical care medicine. And that takes another 2 to 3 years. Right? So there are some degrees. You either have a DM or an FNB or an IDCCM in the Indian context to be called an intensivist. That is what the definition of an intensivist is. Or you could have had similar training in ICUs abroad, like I did. So what is the difference in clinical outcomes that critical care specialists make? All right, so you have improved patient safety, and this is documented. There's peer-reviewed literature to support this. There's a significant decrease in patient mortality and morbidity. There's a decrease in length of stay and in costs for the patients. There's reduced complications, and there's enhanced medication safety. So what was the problem statement that motivated Dilip and me to come back was this. There was a huge physician-to-patient mismatch. So India is estimated to have about 3 lakh ICU beds in the coming 2 to 3 years. And we're going to have about 3,500 or so intensivists. That's how many we have right now. In the next 2 years or next 2 to 3 years, you can double or triple that, and you still have a massive mismatch. And these 3,500 intensivists are largely concentrated in metros and in urban areas. And even within metros and urban areas, they're largely concentrated in large training centers, in tertiary care centers, or in corporate hospitals. So you have a large portion of Indian ICU beds, majority of them that are not in metros and that are not large tertiary care centers that do not have access to critical care expertise. So this was the problem statement that we were trying to address and are still trying to address with some success. So this ratio is here to stay. This is not going to change anytime soon. The need for hospitals and ICUs is still tremendous, and it'll take you about 6 months to a year to open a new hospital or an ICU. It'll take you about 10 to 12 years to train an intensivist. So this mismatch is not going away anytime soon. So what do we do about this mismatch? So we need to find other solutions, and among the other solutions you have two that I'm talking about, and I'll concentrate on one of them. I'll concentrate on technology because that's the scope of the talk today. And so technology is one of the solutions, and the other one is increasing the number of non-physician trained personnel. So, where you upskill nurses, where you upskill, physician assistants. This, of course, requires some government and licensing body support, but this is also a very important part of addressing this problem. So technology is not, the panacea is not going to solve everything. All right, but I'm not going to concentrate too much, but I did want to mention that because I think it's important. So let's just define what the problem is. The problem is that there's a lack of availability of highly skilled critical care personnel. There's inadequate and inefficient utilization of the ICU infrastructure and services. Because of this lack of personnel, there's an inability to deliver high quality care, as a result of which you have medical errors, you have inaccurate diagnosis, you have missed treatment opportunities. And at the end of the day, this affects patient outcomes, all right? So what is the solution? Solution, and this is the solution that I'm going to talk about, is having an integrative Tele-ICU system where you have a centralized command center staffed with highly skilled intensivists that are available 24/7, round the clock, where you have an integrated a system whereby you have automated early warnings, where you have advanced and actionable decision support and diagnostic assistance, all right? So what is a Tele-ICU? Tele-ICU is basically the delivery of critical care from a centralized command center, where by a specialized team of intensivists that are located at an off-site command center, all right? So this is a picture of what our Tele-ICU looks like. That's one of our staff at work there. And you have real-time audio-video conferencing between the command center and the remote site, the ICU. You have EMR and technology platforms that are used to deliver expert care and get data back and forth. So this is, the Tele-ICU is not a new concept. There is strong evidence for the Tele-ICU. It predominantly comes from the West. It has been a proven model in the West. The Tele-ICUs actually found their inception in Baltimore in the late 90s. And there is 15 years of peer-reviewed evidence now that shows reduced mortality, reduced hospital length of stay, lower rates of complications, reduced response times to alarms using the Tele-ICU platforms, right? This is all data that is from the West. We don't have this data in India, and hopefully we'll change that. So this is very interesting, right? I mean, so what the Tele-ICU is doing is basically it's providing you with a command center that's able to monitor your patients, is able to provide you with access to expertise around the clock. And basically this follows the Swiss cheese model, where this is a model that's used in a multitude of industries, whereby whereby one lapse in one line of defense should not allow a risk to materialize, right? So you have a second set of eyes that can pick up an error that's not picked up at the bedside, or you have a second set of eyes, or you have a platform that picks up a medication interaction that is not picked up at the bedside. So this is what this Tele-ICU allows you to do, is reduce the errors and prevent points of failure. So coming to the Tele-ICU and how this technology is being leveraged to deliver value. Number one, with the advent of now that you have connectivity and you're able to connect remote ICUs to a centralized command center which has expertise available around the clock, you're actually providing access to high quality care to these patients, right? And secondly, the high quality care. So you want to provide the technology platforms that you use will decrease the medication errors that you're making, will pick up, alarm systems will pick up warning signs earlier than they could have normally been picked up. So you'd improve the quality of care being delivered. Is it cost-effective care? Can this be deployed in a setting like India in a cost-effective manner? That's really the question. Are we able to do this? So our Tele-ICU is a viable model. This is what I wanted to, I wanted to talk about this slide a little bit because blindly aping, we've seen that Tele-ICUs work in the West, and there's data to suggest that they do work there. There's peer-reviewed literature, and there is acceptance, and you have more and more ICUs that are adopting Tele-ICUs to improve the quality of care. But can that model just directly be replicated here? Probably not, because there are a lot of different, there are a lot of different moving parts here compared to the West. And one of them, just one of them is, in the West you have, in any system that has third-party payer or single-payer systems, there's no differential between the reimbursement between urban and rural centers, whereas that's not the case in India. In India, we are largely a pay-out-of-pocket system, so there is a significant difference in the paying potential in the urban versus the rural patient, right? So you have a limited number of hours in a day, you have a limited number of physicians. The focus is always going to remain the urban market. How are you going to incentivize physicians to take care of patients in, remote India, in Bihar, in West Bengal, in villages in Orissa, when their paying potential is significantly lower than the patients that they're seeing at wherever they're living right now, in the metros or urban areas. So this shift from urban focus will require an increase in the ability of physicians to provide high quality care to a larger number of patients. That's really what you're going to have to do, not merely connect the doctor to a remote place, because that's still not a viable model. There's a limited amount of time this doctor has, and then still has patients who can pay him more in Bangalore. How are you going to incentivize him to see a patient in Shimoga, for example? So technology needs to do more than just provide connectivity, more than just providing, video, audio, and transferring data back and forth. We need smart platforms that would allow physician efficiency to be augmented, all right? So that is the requirement. And technology is not the only thing that would do this, and this is why I had mentioned in one of my previous slides that, upskilling of people is also a part of the solution. So technology is not the only thing that is going to be able to solve this problem. You're going to need more than just that. So one of the reasons why, it's an often heard refrain, but technology cannot replace the doctor's gut instinct. We hear that quite often. Technology can't replace the good doctor's gut instinct. And that's got me thinking. That's, I've thought about it. What actually is the doctor's gut instinct, right? And why can't all the people who say technology can't replace the doctor's gut instinct, why do they say that? Because in a lot of the cases, the technologies that are doing that probably can't do that. For example, a doctor doesn't think like a cardiac monitor, right? A cardiac monitor will give you a blood pressure reading, will give you an oxygen saturation, will give you a respiratory rate, will give you a temperature, and will give you an alarm if you set certain parameters. And you can mix and match the different parameters and come up with multiple parameters that will make that device alarm, which is fine, which may help the doctor, but that's not how the doctor thinks. Doctor has a 360-degree view of the patient, and that's really what, more I think about it, that's really what the doctor's gut is, right? The doctor sees not only the vital parameters, he sees the blood pressure, he sees the heart rate, he sees the oxygen saturation, he sees the temperature, he sees the respiratory rate, but he also sees so many other signals that go into his decision making. Right? He sees what medications the patient was on. He sees what is the patient alert or not? How much urine output has the patient had? Is he making urine or not? What is his history? Does he have any other past medical history, any other conditions that he needs to take into account? What are his lab reports? What does he have any allergies? What does his chest X-ray or his CT scan show? What does he look like? How is he breathing? What is the pattern of breathing? So all of this goes into the decision that a doctor makes, and that's really what kind of comprises the doctor's gut. When we say that will technology replace the doctor's gut, you'll probably need technology that accounts for all of these parameters before you get close to that. So that's kind of where, I want to talk about this a little bit because this is our area of focus as well. That's what we're trying to do. We're trying to improve the doctor's efficiency by addressing all of these different parameters, right? So you have video monitoring, you're looking at the patient, you're capturing images, you're doing real-time image analytics, you're integrating devices and getting data from bedside monitors and from infusion pumps and from the ventilators. You have the patient data repository, you have access to their EMR, or you have access to scan records on which you do OCR, you have access to the labs, radiology, their demographic data, what the history is, what the nurse has said, what happened 5 hours ago. That's going to influence what the doctor's gut tells him, right? So all of this needs to be incorporated into a platform if you are going to expect that to be able to replace the doctor's gut, or at least help with replacing the doctor's gut to some extent, or improving his efficiency. Because just merely having a monitor alarm or merely having a ventilator alarm is not going to do that. You're not going to replace a physician. Even this is not going to replace a physician, but this is certainly going to augment the physician a lot more than just having alarm systems going off that look at a patient in silos, that look at patients in unidimensional views, as opposed to having a 360-degree view of a patient. So this, once you're able to capture enough data from all of these parameters and have it on an analytics engine, that's when you actually can talk about clinical decision support, or augmenting the the clinician's gut as the clinician's gut, as we spoke about earlier. So you have clinical decision support. That still does not take away the need to have an expertise physician input. For the same reason that you can have the most advanced technologies and autopilot and et cetera on a plane, but you're not going to fly that plane without a pilot in it. You're just not going to do that. And it's very similar here. You're talking about mission-critical situations in an ICU, where you're dealing with the sickest of the sick patients. You're trying to prevent them from dying or develop serious morbidity. And so you're going to require a clinical decision support is not going to replace the physician. It's merely going to augment the physician. And that's not all either. Then you need to have effective coordination. You can have the clinical decision support and you have an expertise physician input sitting at a command center, but you need to have effective coordination between the bedside and the command center, whether it is having a good rapport with the nurse, or talking to the nurse, or talking to the patient's family, or talking to the patient, having a video conference, voice text, whatever it be. And this is quite a challenge, actually. This is one of the major challenges in making any tele-ICU or any telemedicine project a success, is the effective coordination. So merely just providing the expertise and providing the technology is not going to solve the problem. Right? So that's really where you get to high quality critical care. Once you can get all of these components in place and get them in the right measure, that's when you're going to see high quality critical care. So again, there are many challenges in the execution. Even if I tell you that, I'm able to augment the physician's gut, whereby I am now a physician who was normally physically able to take care of 10 or 15 patients using tele-ICUs and using these advanced platforms, I'm able to now have him take care or monitor or provide good quality critical care to 150 patients. There's still challenges in actually making that happen, because there are so many stakeholders involved. There's the patient, there's the patient's family, there's doctors, there are nurses, there's the hospital management, and all of these stakeholders need to find a win-win situation in this scenario for this to be a success, right? And our experience has taught us that one solution does not fit all, ICUs are heterogeneous. There are varying resources available. There are varying needs. There are varying levels of training of the ground staff. There are varying levels of acceptability of technology, of being willing to listen to somebody who's not present physically in your ICU but somewhere else. So there are many, many challenges in making this successful. Some of the things that you need for successful execution is you need to assign clinical responsibility and accountability. It needs to be clearly established what the command center is going to do, what the bedside physician is going to do, what they're going to be responsible for, and it needs a coordinated effort between the two to be able to actually deliver high quality care. You need strong leadership and coordination. You need to constantly keep these people engaged. You need to go back and find out what the problems were. You need to build a good rapport with all the nurses, make sure that they feel comfortable in using this technology, make sure the ancillary staff are comfortable in using this technology, because there's so many places that this can go wrong. There are so many moving parts, and so it takes a really very coordinated effort to actually make this work. There needs to be value add for all stakeholders, and we see very often that our efforts to force technology down people's throats sometimes doesn't work out, because it's incumbent upon us to actually get the value add to them. A nurse who's taking care of critically ill patients in an ICU is very busy. She has a lot to do. A patient's really sick. If you're going to ask her to now use a platform and do this that is cumbersome and difficult for her to use and clunky, it's not going to work. She's not going to use it. She's not going to compromise her patient care to use your fancy system. So it needs to be a win-win for all of the stakeholders involved. And so like I was saying, I stress, there are many stakeholders here, and there are many points of failure. And all of the stakeholders need to be shown the benefits and need to be kept engaged. Right? This is again really important for any successful Tele-ICU program. This is a slide. Healthcare in general has been pretty slow to embrace technology. If you just think about the ICU and how it's an area where you have the sickest of sick patients, where you have so many things go wrong, where patients are on the verge of death, and yet we've been slow to adopt systems that would help us improve the quality. That's not the case. I mean, I happen to view the talk on the AI that the AI panel had a couple of days ago, and they also alluded to the airline industry, for that matter, where they've really put in place systems and checks and balances that minimize errors from happening. And we in healthcare, we also need to move in that direction, and the Tele-ICU is one such step in that direction. So what is the future of Tele-ICUs in India? Technology, like I mentioned earlier, technology needs to do more than just providing geographical connectivity. It needs to improve efficiency. It needs to provide clinical decision support, because the model becomes unviable if it's not. If it does not improve efficiency, it becomes very hard to align incentives of all stakeholders to actually go out and provide access to high quality care in remote areas. Like I said, we need to augment the capability of physicians to provide higher quality care to a larger group of patients. Again, I want to stress, this does not replace physicians. We're very, very far away from replacing physicians. We're very, very short on physicians, and I don't think that this replaces physicians. This merely augments their capability. And physicians should also view it from that sense and be willing to adopt technology to augment their capabilities. There's no room for hubris in this. We're talking about the care of patients. These are really sick patients, and it doesn't matter how experienced or how many patients you've seen. If you find something that can improve, provide access, improve quality of care, and do it in a cost-effective manner, it should be incumbent upon us to embrace it as physicians. One of the things that the Tele-ICU will allow us to do, and is very important going forward, is provide us data in a structured format. All of our treatment decisions, all of everything that we do in critical care is for the most part based on data that comes from the West. And we need to change that. We need to find out, because it's very possible that some of the things that are applicable to patients in the West are not applicable to our patients. And we need to have data in structured formats and to be critically, analytically, and academically looking at this data to actually see what works in an Indian setting. And I believe that going forward, Tele-ICUs should be part of that solution. So this is a list of questions that I got, again, from the AI panel. And I thought I'll just answer them in the context of Tele-ICUs. Is the technology anywhere close to prime time? The more I thought about this, I don't think there's going to be the more I think about this, there isn't going to be a eureka moment. There isn't going to be a moment where, somebody wearing a Steve Jobs like, black t-shirt is going to come out and give you a smartphone and change the way things are. That's not going to happen. It's going to be incremental success over success, which is going to require a period of time. But are we there? Yes, we are there. We are seeing connectivity in places that never had connectivity, so it's incumbent upon us to find solutions and provide them with access now. Role of medical practitioners when and if such technology becomes mainstream. Again, like I said, medical practitioners will only be augmented. I do not see them being replaced. As such, I think medical practitioners should embrace technology to help them be better doctors. And again, like I said, you're not going to fly, no matter how good your technology is, you're not going to fly a plane without a pilot. Similarly, you're not going to run an ICU without a doctor. Will receivers of medical service become more involved and knowledgeable? Again, I think, it's incumbent upon us as the deliverers of technology or the deliverers of healthcare services to provide value to the receivers. And if we are able to provide value, they will embrace it more and more and will become more involved and more knowledgeable. The more I think about it, if 15 years ago, if you asked me, if my mother could, take a snap of her grandchildren and upload it on Facebook within 5 seconds, would that be possible? I would have said no, she can't. But right now she can do that faster than, the geekiest nerd that you'd find. My mom can actually do that. That's because she finds value in doing that. So, she's adopted it. And I think the same is going to happen even in healthcare. A patient who is in Shimoga or in rural Karnataka would much rather be close to their home and get high quality care there than travel to Bangalore to take 3 or 4 hours. It's probably not even clinically, in their best interest to do that. But if you could provide them with high quality care where they are, they'd probably be better off and they would adopt it. Will there be big players controlling all of our healthcare data? Hopefully, there will be a place on the table for everybody who has, innovative ideas and innovative solutions that help improve the quality of care that's being delivered, that help improve access to care. So I think this will require some form of regulatory oversight whereby, there is data sharing and there is interoperability, because that's what's going to, allow us to come up with more and more innovative ideas and solutions. What are the technology inflection points? With respect to the Tele-ICU, I would say, we're probably there, because regarding Tele-ICUs, I think the inflection point comes with providing connectivity. And we're there. We're pretty close to getting most of this country connected. And if we can get them connected, we should be able to build something that provides them with high quality care. So that's all I've got. I'll open the floor to questions. Yep.
Very nice presentation and very nicely articulated. One of the problem, probably, is that so it depends on the data. Right? Data will come from the equipment. Right? And equipment have a lot of formats and there's a lot of issue in getting the data. In fact, some of the ICU monitors, They're not open to share the data. So how you have circumvented that thing?
Yes, that's a huge challenge. A majority of Indian ICUs don't have HL7 compliant monitors. And initially, when we were devising our solution, we thought, okay, this is a deal breaker, but it turns out it's not. All right. So the way that you circumvent it is you need to find other innovative solutions, whether you use people to get data or whether you use video to get data. There are different ways by which you can get data, but you can get the data. So yes, you need to find cost-effective means because it's not logistically possible to expect every ICU in India to switch over to interoperable systems because, as you know, that's a really expensive proposition. Yeah, go ahead.
Doctor, I have a question, may not be a right example. 15 years back, I used to remember at least 54 numbers.
I'm sorry, could you repeat that?
15 years back, I used to remember at least 54 numbers.
Okay.
Today, I don't even remember my wife's phone number, dangerously. I'm wondering, people like you, will you become better by technology, or you become less efficient, dependent more on technology? That really bothers me as a technical person.
Okay.
I mean, helping you or,
Okay.
yeah.
I think that question should just be answered by what provides better outcomes. All right. That's really where the answer to that question lies. If the adoption of technology for the sake of technology is useless, right? So let's not force things down people's throat just because we think. Let's not make solutions and then find problems for those solutions. Let's find what the problems are and make solutions for those. So my answer to your question would be, if you can objectively show that adoption of something improves access or improves outcomes, then it should be adopted. Even if that means that I may forget more phone numbers, it doesn't matter if the patient gets better care. That's our goal at the end of the day.
Without technology, I can do the That is situation. Without technology, I can't do anything. I can't do anything. Okay. So access to technology for some reason is limited. So will that...
emergency scenario. So is there any published literature or anything in terms of the response is still today pretty tech-free, like in disaster situations?
So interesting question, and again, I would go back to, we have a lot of problems. We deal with ICUs in India, so as you can imagine, connectivity is even though it's there, is sometimes choppy. For the most part, we are providing services that the bedside does not already have. All right, so even if we were not there, if I was not there, they would be doing something. What I'm doing is I'm coming there and I'm just helping them do it better. Right, and that's our focus. So our goal is, like I said, we don't go and tell anybody, oh, you know what, you don't train your people, or you don't hire somebody, or you don't need a doctor, you don't need it. That's not what we do. Right, so all of those, the fact of the matter is that we find ourselves at a place where we are very far from providing high quality care to a lot of these places. And so we are just augmenting those people do that.
So my question is related, but in the opposite direction. So I like your target of going from 1 to 15 to 150 to 1. What is the mental capability of an intensivist to actually handle?
Okay. What is the mental ability of the intensivist to handle 150 patients? So like I told you, one of the things, and I didn't focus on I just mentioned it briefly, was that technology is not going to be the only answer. It is going to require upskilling of other people as well. You may not need an intensivist at that level, but you will need other people who can address specific questions and escalate things to an intensivist as and when needed. That would allow an intensivist to actually reach out to 150 people. So it's not going to be technology, purely technology, yeah.
Got it. Thank you.
Yeah.
How do you compensate for tactile other than view? Like this,
Yes.
I mean, doctors be spoken for.
Yes, yes.
How do you compensate?
Yeah. So touching is an important part of a physician assessment, and that needs to be accounted for. And so that's, again, you know, a lot of the time we need to have a close coordination with the staff at the bedside. Yes, and it is subjective. There are some objective parameters that can be made. Now, for example, you know, if somebody comes in with the knee swelling, I want to know, is it warm or not? Because that's going to determine whether is it an infected knee or is it just something else that's benign. So yes, there are these, you know, there is touch forms a part of a physician's assessment, but it can be done in coordination with somebody who's at the bedside. That is certainly possible.
Okay, I guess can we take this offline if you don't mind, because we are running out of time. Yeah, thanks Dr. Dhruv for a wonderful presentation and answering the questions. And I request Pooja Kadambi, who is local organizing co-chair, to actually hand over a memento to Dr. Dhruv.